Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. Today's video is about an umbilical adenoma. An umbilical adenoma results from an abnormality in the formation of the umbilical cord, and it is usually as a result of failure of the closure of a structure called the vitreointestinal duct. This abnormality usually occurs during fetal development when the unborn child is still in the uterus.
In order for us to understand what happens in this condition, we have to understand how the umbilical cord is formed. Everything starts from the stage of fertilization, when the sperm fertilizes the egg in the ampulla of the fallopian tube. After fertilization, the fertilized egg has to transition to another stage called the stage of cleavage, where it undergoes cell division to form a cell mass called a blastomere, and it contains 8 cells. This usually happens around day 2 after fertilization. At around day 4, the blastomere has to transition to another stage called the morula. The morula is a result of cell division, continuous cell division, where the blastomere now has to continue dividing into other cells. The cells can multiply up to around 16 to 32 cells, and this entire cell mass is called a morula. Once in the uterine cavity, the morula has to go to another stage called the stage of blastulation. During this stage, the morula has to undergo several cell divisions to form a cell mass called a blastocyst. The blastocyst has 2 cell layers. It has the inner cell layer called the embryoblast and an outer cell layer called the trophoblast. At around day 7, the blastocyst has to transition to another stage. That is the stage of implantation, where it gets attached to the walls of the uterus, specifically the inner wall of the uterus called the endometrium. During the stage of implantation, the outer part of the blastocyst, that is the trophoblast, has to divide into 2 cell layers. That is, it has the outer part, the outer cell layer called the syncytial trophoblast and the innermost part called the cytotrophoblast. Now it is the syncytial trophoblast that digs deep into the endometrium, the walls of the uterus, the inner wall of the uterus, allowing attachment of the blastocyst onto the endometrium, that is the uterine wall. By day 12, the blastocyst has to transition to another stage, and that is the stage of bilaminar disc formation. During this stage, the inner cell mass of the blastocyst, that is the embryoblast, has to divide into 2 cell layers, that is the epiblast and the hypoblast. At day 14, these 2 cell layers, the epiblast and the hypoblast, grow in such a way that they form fluid-filled cavities above and below the midline of the blastocyst, respectively. The fluid-filled cavity formed by the epiblast is called the amnion, and the one formed by the hypoblast is called the yolk sac. By the 3rd week of gestation, when the unborn child is still in the uterus, the epiblast forms a layer of cells called the extraembryonic mesoderm. This layer of cells lines the inner lining of the trophoblast. The extraembryonic mesoderm will later form a connection between the embryoblast and the trophoblast, and this connection is called a body stalk. The body stalk is one of the components of the umbilical cord. At around the 3rd week of gestation, when the unborn child is still in the uterus, the embryoblast will transition to another stage. That is a stage called gastrulation. This means that it will have 3 cell layers instead of 2 cell layers. This process usually starts by formation of a structure called a primitive streak on the surface of the epiblast. After formation of the primitive streak, we shall have the first wave of movement of the cells of the epiblast through this primitive streak, and these cells will move in a way that they will enter deep into the embryo, displacing the hypoblast, and these cells form a cell layer called the endoderm. After the cell layer that formed the endoderm has migrated, we shall have another cell layer that will migrate from the epiblast through the primitive streak, and this will occupy the place between the endodermal cell layer and the remaining part of the epiblast, and this will form a cell layer called the mesoderm. And so the remaining part of the epiblast will form the cell layer called the ectoderm. So you can see that by the end of this process of gastrulation, we have three cell layers. We have the endoderm on the inside, we have the mesoderm in the middle, and then we have the ectoderm on the outside. So each of these cell layers will form the different parts of the body. For example, the endoderm is going to form the gut tube, which is going to be divided into the foregut, midgut, and then the hindgut. It majorly forms the gastrointestinal tract. It is also responsible for the formation of other organs, for example, the pancreas, the liver, and the gallbladder. Still at the 3rd week of gestation, when the unborn child is still in the uterus, the embryo is going to undergo folding in a craniocaudal fashion. That is, it will fold on this side where the head is supposed to be, and also this side where the buttocks should be. So it folds in that direction on both sides. And this also causes folding of the endoderm, the inner cell layer. That inner cell layer that was initially formed, that was first formed in the gastrulation phase, is going to also be folded into a gut tube. And this gut tube has three segments. It has a foregut, a midgut, and a hindgut. While the endoderm is being folded into a gut tube, the yolk sac will as well be folded, and it will also form part of the gut tube. And part of the yolk sac will be left connected to the midgut of the gut tube that has been formed. The connection left between the gut tube, that is the midgut, and the yolk sac is called the vitreointestinal duct. The vitreointestinal duct is the second structure that forms the umbilical cord. Still at the 3rd week, at the hindgut part of the gut tube grows a pocket, an outpouching, and this grows into a structure called the allantois or the allantoic duct. The allantois or the allantoic duct is a structure that drains the urinary bladder. The allantoic duct or the allantois is the 3rd structure that forms the umbilical cord. So you can see that we have formed the 3 structures that form the umbilical cord. These 3 structures that we have so far formed, that is the body stalk, the allantois or the allantoic duct, and the vitreointestinal duct, together with the 2 umbilical arteries and 1 large umbilical vein, form the entire structure of the umbilical cord. At the 4th week of gestation, when the unborn child is still in the uterus, the amnion also undergoes folding. Remember that the amnion was formed by the cells of the epiblast. The cells of the epiblast grew and formed a fluid-filled cavity. So it is now this fluid-filled cavity that was formed by the epiblast, the amnion, that now grows downwards to envelope the rest of the embryoblast. The folding of the amnion kind of brings all the structures of the umbilical cord together, and it also forms the outer lining that covers all the structures together, that is the body stalk, the allantois, the vitreointestinal duct. So at the end of the day, we have a fully formed umbilical cord. And by the 7th week of gestation, when the unborn child is still in the uterus, these 3 structures, that is the allantois, the body stalk, and the vitreointestinal duct, are going to emerge through the abdominal wall of the fetus, and they are going to emerge through a small opening called the umbilical ring. as the structures composing the umbilical cord. The other structures that will also compose the umbilical cord will include one large umbilical vein and two umbilical arteries. At the end of week 7, there is a disappearance or a shrinkage of the vitreointestinal duct and the yolk sac.
Failure of the closure or the shrinkage or the disappearance of the vitreointestinal duct or the yolk sac can result into certain conditions. For example, the congenital intestinal fistulas, the umbilical adenomas, the Merkel's diverticulum, the intra-abdominal cysts, and the congenital burns. At around the 8th week of gestation, when the unborn child is still in the uterus, the allantois or the allantoic duct is also meant to close off, disappear, and shrink. And this leaves behind a remnant called the urachus. If the closure does not happen, you can end up with a patent urachus, meaning it is going to be left open. And this can result into certain conditions. For example, the urancofistulas, the uranchosinuses, the uranchocysts, and the uranchodiverticulum. In a setting where the vitreointestinal duct remained open, closer to the umbilicus, we can end up with a small opening discharging mucus, a condition called the umbilical adenoma or the raspberry tumor. It is usually as a result of the protrusion or the eversion of the mucosa, that is the inner lining of the remnant of the vitreointestinal duct. It usually presents as a small opening or a red swelling protruding out of the umbilical stump. This red swelling on the umbilical stump is usually moist with mucus and it bleeds on touch. When we touch it, blood will come out of it. Infection can also set in, and this can result into pus discharge from the umbilical adenoma. I want to bring to your attention the umbilical granuloma, unlike the umbilical adenoma, happens after the child has been born. It is acquired, and it is as a result of chronic infection of the umbilical stump. However, the umbilical granuloma is also going to present as a painful red swelling protruding out of the umbilical stump, and it can discharge mucus and also pus. So it can easily be misdiagnosed or confused for the umbilical adenoma. Especially for the health workers, you have to be vigilant about that, because the management, although it can be cross-cutting, but there are some treatment modalities that can work for the umbilical granulomas that cannot work for the umbilical adenomas, especially the silver nitrate treatments. The silver nitrate treatments cannot work for the umbilical adenomas, but they can work for the umbilical granulomas. So I just wanted to bring that into perspective, such that you can be vigilant not to mix the two conditions. It is very, very easy for you to mix them up. The investigations that we carry out include a discharge study, where we take off a sample of the discharge from the umbilical adenoma, and you can carry out some tests. You can do a culture and sensitivity, you can do a Zn and a gram staining. And this is usually aimed at finding out the microorganism or the germ that is within the discharge of the umbilical adenoma, especially if there is infection going on. We can as well do a cytology, where we look out for presence of cancer cells. When it comes to the treatment of the umbilical adenomas or the raspberry tumors, we can employ antibiotics, especially in a setting where there is infection. However, the definitive management or the real management is surgical intervention. We can employ ligatures, for example, for the pendaculated umbilical adenomas, the ones that have a stalk. So what we do, we can get, for example, a nylon suture, and then we can tie at the base of the umbilical adenoma at the stalk, the base of the stalk. And this can allow the umbilical adenoma to fall off. If the ligatures don't work, we can employ a surgical procedure called umbilectomy. Umbilectomy entails the complete removal of the umbilical adenoma together with the umbilicus, the belly button.
So the take-home message is, please be on the lookout for any red swelling that is protruding out of the umbilical stump of your child. Majority of the time, this swelling is moist. It is covered by mucus and it bleeds to touch. Your child might have recurrent infections in this swelling, and this will be recurrent until surgical intervention has been sought. So please bring these children to the hospital, because we can just do a minor procedure and the condition will just disappear.
And to emphasize, we must know how to differentiate between the umbilical adenomas and the umbilical granulomas, because the umbilical adenomas will not respond to silver nitrate, but the umbilical granulomas will. So we don't use silver nitrate in umbilical adenomas. We only use it for umbilical granulomas. The umbilical adenomas tend to be present at birth, and the umbilical granulomas are acquired from a series of chronic infection of the umbilical stump. So thorough history has to be taken, and this differentiation has to be made. Yes, that is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video. Bye.